I believe we are live right now. This is United Medical ACO, our weekly update for our patients. We have a lot of items today, very important things to talk about, and we do want to give you some updates. But before we do that, I want to introduce myself. My name is Kemal Erkan. I'm the chairman of United Medical ACO, and today I have Dr. Barnett-Smith from United Medical Clinic. So she's going to be with us and discuss our topic and give her opinion on the topic that we are going to discuss. Dr. Barnett-Smith, if you can please introduce yourself.
Good afternoon. Thank you, Kemal, for having me. I'm excited to be here. My name is Barnett-Smith, and as Kemal said, I am a physician with United Medical Clinic in Becks Woods in Bear, Delaware. I've been with United Medical since 2011, and I am also a proud wife and mother of 2 teenage kids who are currently virtual schooling today. And I'm excited about what we're going to be speaking about today.
All right, thank you. So, Dr. Barnett-Smith, this is the weekly setting that we have now. So what I do is I do provide some of the updates for our patients, and whoever is actually in Delaware or in the United States, they can also, of course, watch this as well. So similar to our provider meetings, you are part of those meetings. We have done about 101 of them, 101 total sessions since March 29th. And you do participate on a regular basis, and you'd also present as a panelist in those, and we do thank you for that. We wanted to discuss the very important issue that we have as with the pandemic kind of got out of control. It became a bigger problem perhaps, and we were able to actually understand a little bit better with the racial disparities with the COVID-19 and also racial injustice in a way, that how we can actually, what this problem is, how real it is, what we can do from our practices, from our medical staff, and from the society standpoint. So that's what we were hoping that we would be able to cover today. So before I start with our topic, I do want to, for those who hasn't seen this before, what United Medical Services are. We have several different business office services for medical practices with the medical billing, EMR, and also accountable care, and there are several others, and they can find these informations on our website, so I'm not going to actually go into the details. One of the things that we are focused on is most of the providers and, well, most of the people in healthcare, they would hear the triple aim, which we actually wanted to take this to a quadruple aim, where including the physician and physician practices into this mix, because one of the issues that we have is when we say triple aim, so we were talking about improved health, lower costs, and better patient care. How can we do that if we don't have our providers and our practices in place? So that's why we wanted this to be part of our group elements, so that we know that this is a quadruple, and we can add several others, but we really believe that triple aim foundation or the base was not enough. The physicians, providers, especially when we know the shortage is there, this is extremely important, and I'm extremely happy that we are able to be part of providing the services and keeping our providers in business. So that is something that I wanted to share. Now, from the United States total number of cases, I do keep it in this format. Dr. Barnett-Smith, we are kind of used to this, and you probably have seen it already 90 times, but just for the public, so they can kind of see these side by side, where we were as of 4/15 with 1 million cases, and now we are almost at 7 million, so that's about 700% more. And we do want these to be very carefully analyzed by everyone, because everything that we do at the individual level has a big impact in the overall society, and I'm hoping that we can actually impact some of the individuals and their approach on pandemic. So there are about 202 people died so far. This is the confirmed number. This is a big tragedy if you look at this number for something that's so new and so quick. How many people we have lost? It's not something that we can be okay with, and I'm hoping that we can make an impact on these. Now, Delaware is as our home state. We do share the new hospital admissions. These are the last 14 days, and also the new positive cases, the ratio of the number. And usually this orange bar here is not something that we have to pay attention necessarily, but we need to look at the blue bar and the trend of the blue bar, and as it's the 14-day average. So that number is going to be more accurate. And if there is an increase or decrease, that's important. As you can see, there is an increase in the total ratio of the positive cases, and we want to make sure that we can share these with you, and you can actually have a good understanding of what's happening from here. Now, the topic that we wanted to discuss, Dr. Barnett-Smith and we have a similar session for our providers, and I personally wasn't sure what I was going into. She and I, we've been working together for close to 10 years now. It was 2011, I believe we started. And when the issue is sensitive and something that I may not be extremely comfortable or knowledgeable, I went to her and asked her if she could actually help me during the provider presentation for this issue. So the I'm trying to actually bring my screen up at the same time, so that's one of the reasons I'm pausing. So the way that we see this is what you see here from the Center of Disease Control and Prevention from CDC website. So this is a real issue of the health equity consideration and racial and ethnic minority group, the discrepancy and the service not being available, treatment not being there, resources are not being there. This is a real issue. Now, when I was reading, especially with the pandemic, I had to do a lot more reading than before. And I realized that we were not paying enough attention to the problem. Now, this article from Becker's Hospital Review Group, part of our weekly update, we include different news. And personally, it made me very uncomfortable. Just reading it was not, and then trying to be correct with the choices of the word itself, and asking my friends, like it's, is it okay to use this? Is it okay? Like we still have those issues versus, well, there's a real problem. So this is where I'm going to ask Dr. Barnett-Smith if she can help me to better understand and help us to better understand from the physician standpoint what this issue is. Like, Dr. Barnett-Smith, do you believe that this is a real issue?
Absolutely. The interesting thing about these type of articles and how they're highlighting the racial disparities with COVID-19 is that it's really important for us to remember that this didn't start with COVID-19. The reason why we have the disparities between ethnic groups is far-reaching. This is something that has been an issue for some time, and COVID-19 was a way to really highlight it. One of the things that is difficult for me as both a physician and a person of color is that I sometimes am able to see these disparities and the reasons for them quite clearly, but don't always feel like I have the necessary means to make those changes. And I appreciate you, Kemal, for wanting to have the conversation, because I think that's very important, that one of the things that our racial minorities, our ethnic minorities need to know is that they're being seen and their concerns are being heard. COVID obviously has taken a toll on everyone. It has not been something that has been particularly pleasant for anybody, but the Black, Brown, Asian communities, the Native communities that have been affected so deeply have taken such a hit because of the issues with healthcare that have been in place way before the pandemic, the issues that have been in place with the way that our system works in this country have been in place since way before COVID. And as you said, you were uncomfortable in reading some of these articles, but I think that's important. I think it's important to be uncomfortable, and I think it's important to face your discomfort so that we can truly make change. Ignoring it doesn't help. Saying it doesn't exist obviously doesn't help. So getting in the trenches and confronting those uncomfortable topics is extremely important.
So, Dr. Barnett-Smith, when I was reading some of these articles and trying to educate myself on this issue, you know, again, what we hang up is like, what's the right term to pick? Now, actually, you may remember when I was presenting this in the provider meeting, this is directly from Becker's group, and when they use the term Black, and I was actually overriding with African-American. Mm-hmm. Which one is the right way to address this?
Sure. I think that when we're talking about ethnic and racial disparities, Black is probably the better way to address it for several reasons. One, when you say African American, you're assuming that the person's American. What if they're not? What if they're an immigrant that is of African descent, or somebody specifically from Africa? So I think that while it is, I'm trying to think of the best way to say this, but I think it's admirable that people want to make sure that they're using the right term, but we also sometimes get so bogged down with trying to find the right term that we leave people out, because I have African friends and people from the Caribbean who take, you know, umbrage with being called African American because they technically aren't American. So I think in this aspect, saying Black is fine, because we're capturing all those groups that are being affected.
No, that actually, you know, that helps, because the problem is this. So if I'm paying attention to things that are not the real problem in this article, where we want to see the main problem, and I don't want that issue to prevent me to go into the real problem. So then sometimes people don't want to talk about it. Mm-hmm. So just because they're not feeling they're not picking the right word, and they're like, okay, I'll stay out of this, and that doesn't help. Now, I still have a difficult time when going back into this article. Now, I'm just reading this. For COVID-19 patients, it's 3 times more likely to be hospitalized for Black community. How is that possible? Like, why are we at that point?
So let's talk about what makes people high risk, right? So you have things like hypertension, diabetes, obesity, chronic medical problems, asthma. Those things are hitting the Black community harder than other ethnic groups. And so you're already at somewhat of a disadvantage because you're more likely to be in a high-risk category. Then we will talk about, not just from a health standpoint, but from a social standpoint, the ethnic minority groups have been hit harder because they've been more likely to be seen as essential workers and having to go in at the height of the pandemic when people weren't necessarily having the right PPE to protect them. And it was a choice of staying home and trying to protect their health versus being able to earn a paycheck. So that also put people at a disadvantage. So you have a high-risk person who's forced to go into work and then they get exposed to COVID. It's going to definitely impact that community a lot greater. The other thing I will say is that for some patients, this is not everyone, but for some patients in minority groups, they have been reluctant to seek out medical help early on, whether that be because of cost, if they're uninsured, or they didn't have a place to go, or they were scared of being labeled or ostracized because of a COVID diagnosis. And so sometimes they were getting identified later when they were much sicker, and that leading to hospitalizations as well.
So the other thing that I see is even in different states, like from the different part of the problem. Now, when you look at the total number of people who are actually hospitalized in Louisiana, so that's 77%. The other one was at 80%. Now, the other part of the issue, again, is what happens after COVID, like once they're infected. And then there is also the discrepancy and injustice in a way that the quality of life is affecting their recovery. And this is something that, not just from the healthcare side, but from the community standpoint, I felt like there are so much that we can do. Now, as you know, we have a licensed social worker as part of our program, and our dietitians who are also helping with the telemedicine. Now we are trying to put more support out there. And one of the reasons actually we are doing this call, as you know, we didn't have these presentations before, but it kind of pushed us to be out there for everyone to be able to share what's happening from our side and how we are actually processing these. And the way that telemedicine that we start using. So I want to kind of ask the question specific to this issue with telemedicine. Do you see in your practice, do you see any discrepancy in terms of how it's being used by different group of people?
I think that we definitely see more difficulty in our older population, and that goes that's spread equally, I think, amongst the racial and ethnic groups. But what I see personally is that my minority patients tend to be more grateful that we're doing telemedicine and that we're offering them a chance to not come into the office and to be exposed unnecessarily to anything, whereas members of the community that aren't being as affected as much tend to balk a little bit more about the fact that we're trying to limit our patient in-person visits at this time while we're still trying to get a hold of the pandemic.
So, sometimes we don't really get enough credit. Well, when I say we, I really mean you and our providers. Since one of the statistics that I have from us as a network in Delaware, we have seen a little bit more than 93,000 unique patients, individual patients, with 225,000 appointments. Now, most of these appointments happen through telemedicine, and our goal was to keep them in their home and keep them safe. But you still have some patients who come to the office.
Yes.
How do you deal with the in-person visits these days? How is that working out so far?
So we handle in-person visits as treating everybody as they're COVID positive. So we are in full personal protective equipment, and we require that people who are coming into the office wear masks. We do a COVID-19 screening before they come in. They get their temperatures checked as they're entering the building to make sure that they don't have an elevated temperature. And we are doing our visits less frequently than we would when things were business as usual. So usually there's no more than a patient, 1 or 2 patients an hour, so that we have time to clean the rooms, make sure that they've been thoroughly disinfected before the next person comes in, and that we're not having a lot of interaction between patients in hallways, in areas where there's really not a good way to be able to socially distance.
So from the telemedicine side, I start sharing this just so that we can actually put some communication out there, do's and don'ts of the telemedicine, and just from the patient standpoint, how they can actually prep for the visit. So I do want to just share this on our session so that if in case they don't watch the other ones, so they can get an idea. So this is going to stay there for long term. Like, you know, one of the other things that we are doing is the patient portal. If they're not utilizing their patient portal, these visits are not going to be as smooth. But when they engage the IQ Health patient portal, it makes it extremely more efficient and easier. So we are trying to put these out there. Now, the event that we do, Dr. Barnett-Smith, as you know, like from the CREAS, our bariatric program side, we have done one this week. It was Wednesday. This is our second one. This event is our second one today. And next week, we'll have 2 events on Wednesday night, one from CREAS at 6 p.m. And the other one is our wellness program with the patient with diabetes. That's at 7 p.m. on Wednesday. And then we'll have Humana actually joining us next Friday.
Oh,
now, the Humana joining that meeting is important. Many patients, if they have Medicare, they already know what Humana is. But in case they don't know, it's a Medicare Advantage program. It's an insurance company, and then for those who are on Medicare, they can actually choose to work with one of these insurances, and we'll have a Humana rep as we are they're part of our ACO. We do want to make sure that on the open enrollment for the Medicare, patients can get the information and what's available for them. So we'll be hosting them for that event. You know, I have to tell you that with these conversations are extremely helpful. And every time I feel like I'm learning something, I want to share with everyone else. And just so that, because I feel that way, I'll try to do this more and more. From our side, from the business office side, are there anything that we can do that we are not able to do today? We are not doing maybe today. What can we do to make it easier for our providers, our physicians?
In terms of the racial disparities in healthcare?
Yes.
Okay. So one of the things that I think is so extremely important, and I think this is not something in the ACO, I think this is just something broader, is that I feel that in a lot of ways we've lost our ability to listen. And I think that that is so important. Even when you don't agree with somebody, being able to hear them and to really hear them, not just listen to the words that they're saying, but trying to understand what they're trying to get across to you, is extremely important on just meeting people on a human level. And I believe that one of the reasons why we have such an issue with health disparities is that pretty much from the beginning of the start of this nation, people of ethnic groups have been seen as something other than human, right? So you have, you're missing that basic connection. If you don't meet somebody on a human level because you don't see them that way, it is very difficult to be able to empathize with them, to be able to try to begin to understand their experience. We're not going to be all the same. I'm not going to be the same as you, Kemal, coming from a different country and immigrating here and creating a business. My experience is going to be different than yours. But if we can listen to one another and, like you said, be willing to be uncomfortable, to hear what people have to say, we'll get so much farther than where we've been for the last 400 years. But what I will say from an ACO standpoint is I think it's important to have these kind of discussions, and not just from a Black standpoint, but let's talk about our Native community and our Asian community, and having people come on and give their perspectives. I think it's so important because people need to see things from outside of themselves. And when we can do that, and when we can show each other that I may not be able to fully understand, but I hear you and I respect what you have to say, it makes things so much easier. It makes people want to be able to trust you. It makes people want to be able to come back to you. They just want to feel acknowledged, and they want to know that they've been listened to.
Well, it's extremely important, listening and understanding, and I agree with you. And this is so important for us, and it's important for you to join us and share your position on this and educating us. I feel a lot better when we are communicating and when we are approaching the problem to solve the problem, not just be part of the problem. And there are so much we can do, and we are going to try to do more and more. And I'm hoping that our patients can hear us loud and clear. We are here to help them. We are here to help everyone at the same level. And again, Dr. Barnett-Smith, it's a pleasure to have you in the session, and we'll see you soon again. Thank you so much.
Thank you.
All right, have a good weekend, everyone. Bye-bye.